Good evening, everyone, and you're very welcome to this BTOG Masterclass on diagnosing lung cancer. It's a pre-lockdown special. We've got a expert panel this evening to go through some of the current and controversial issues around diagnosing lung cancer. Must thank our colleagues on BTOG for organising this, and also our sponsors, Guardant Health and Amgen. If you have any issues, I'm reliably informed that Dawn and Gina from the BTOG team are on standby to answer them, so please do contact them via email. You can submit your questions, and we'd really encourage you to do so. We want to make this as interactive as possible. Please submit your questions via the control panel on the side of the screen, and do this at any time, and we will stop at various points to answer those questions. As previously, you'll receive your certificate of attendance after we've received your feedback, and there's the RCP approval code for your points. So we're going to have quite a packed agenda. We're hoping to get through 6 key topics. So firstly, about the optimal pathway, then about EBUS, then on performance status, smoking cessation, some controversy about MDTs, and we're also going to touch on liquid biopsy. Here are some of my disclosures. So it's a real pleasure to introduce the expert panel we've assembled today. Unfortunately, Dr. Matthew Everson is currently dealing with a medical emergency and is hoping to join us as soon as possible. But if I ask the panelists to introduce themselves, so firstly, Dr. Sadia Anwar.
Hello, hi, I'm Sadia Anwar. I'm a chest physician at Sheffield Teaching Hospitals.
Dr. Arjun Nair.
Hi everyone, I'm Arjun, a chest radiologist at UCLH, University College London Hospital, and an associate honorary professor at UCL.
Josie Roberts.
Hello, I'm Josie Roberts, Macmillan lung cancer nurse at the Rotherham NHS Foundation Trust. I'm also a committee member for Lung Cancer Nursing UK.
And Dr. Beth Sage.
Hi, I'm Beth Sage. I'm a respiratory consultant at Regmore Hospital in Inverness.
And I'm Neil Navani. I'm a chest physician at UCLH. Right, let's get straight into it. Now, while our heads have been turned quite rightly towards COVID, you may not have noticed, but the National Optimal Lung Cancer Pathway has been updated. And version 3 was recently published with a couple of interesting updates, particularly around diagnostic bundles and time treatment pathways for thoracic surgery, medical oncology and radiotherapy. So if Sadia, if I could ask you, what are the main challenges and solutions to implementing the optimal pathway from your perspective at the moment?
Thank you. I think I'm going to divide this into the sort of pre-COVID era and COVID era, because we all thought that the challenges were tremendous, huge, and possibly this was even unrealistic to deliver, and that was even before the COVID pandemic hit us. I think the challenges initially can broadly categorised into firstly getting buy-in from all the right people to deliver this, because it is ambitious and it is challenging. Secondly, it was in terms of organising services. We are a complex tumour site which cuts across multiple specialties, multiple directorates, and the way our services are organised makes it very difficult to implement change that cuts across the whole of the pathway. And thirdly, of course, it involved expanding capacity at every level in every single part of our pathway. So this was no mean feat, but many solutions presented them fairly readily. Nationally, obviously, once we gained NHS approval for the NMLCP, that meant that effectively trusts were mandated to deliver this, and that was hugely important in terms of being able to persuade people. Cancer alliances were then developed to coordinate regional services as well as funding, so that we could, most hospitals work on a hub and spoke model, and we needed that regional configuration to successfully implement this. We also benefited from GIRF developing a separate work stream for lung cancer, and that's been hugely helpful in terms of assessing each hospital against these timescales, these milestones, and then actually holding us all to account in terms of delivering this. Locally, my previous role, I was a chest physician at Nottingham, and I led a project to try to implement this, mainly as a response to our very poor cancer waiting times. And I think that one of the most important functions we can serve is actually advocacy for this for our services. It's important to emphasise that clinical and corporate aims are completely aligned, because our corporate colleagues want our cancer performance to be improved, excellent. We want that as clinicians, and our patients want that too. There's also a very good evidence base for faster pathways in terms of patient outcomes and patient experience, and we shouldn't forget that, because we all know that, but I don't think it's always clear that when we're speaking to other people outside our services that that's appreciated. We need to know our local data, and we need to process map our services so that we can then implement the changes that we recognise are needed, and we can make the business cases, because if we don't ask for things, we won't get them. Then COVID happened, and I just wanted to draw your attention to a report from the UKLCC called COVID-19 Matters, which was recently published. And I think this slide really nicely summarises the fact that we cannot overstate the impact of COVID-19 on our services, and it's been an absolute tragedy for our patients, really. And you can see that at every level, it has impacted on the care of our patients. Lung cancer CT screening pilots were stopped. We know that referrals to the 2-week lung services fell dramatically, so nationally down to about 30%. There was also a reduction in referrals for chest x-rays. We had restricted access to our own services in terms of our diagnostic capacity, and particularly EBUS was a problem, because obviously AGP, there were far fewer procedures going on. We had staff off, and because of the condition of our bronchoscopy suites, our endoscopy suites, the capacity within each list was further reduced. Treatment schedules changed. The delivery of palliative care was made more difficult, because obviously patients couldn't have visitors, for example, and lung cancer clinical trials and research was stopped. So hugely dramatic. And I think it's fair to say that although this affected a number of clinical specialties, lung cancer was one of the hardest hit, and it was one of the tumour sites that was most slow to recover in terms of cancer referrals. There are a number of things that we can do to try to, in parallel, we have to accept that we have to live with COVID, and our patients can't afford to wait till COVID is over for us to, give due attention to our services. I think it would be remiss of me to mention anything about the NLRCP without emphasising that there's no point having a fantastic pathway if no one's referred in. And so I think our primary aim should be to engage with awareness campaigns, both in terms of the public and primary care, to make sure that patients are still being referred in, to make sure that the mantra of got a cough, get a chest x-ray hasn't changed to got a cough, stay at home. It's really important that we send that message clearly. A number of initiatives have been proposed that actually align nicely in terms of protecting our patients from COVID, as well as delivering on the NLRCP performance. We need to make sure our patients are safe from COVID as far as possible, and that means trying to establish clean sites and dirty sites, and what is being advocated previously that fits nicely as diagnostic community hubs, where these centres are more likely to be closer to patients' homes, easier to access, hopefully clean sites, COVID-free or COVID-light, where patients can undergo CT scans, blood tests, spirometry, for example. The further benefit of that is it also reinforces the model of one-stop shop, so minimising the attendance of patients in secondary care facilities, and in theory, hopefully reducing their exposure to COVID. It's also important that we look at endoscopy capacity, and obviously, as I've mentioned, EBUS was particularly hard hit. I think we do need to explore those possibilities of moving some endoscopy procedures out into, for example, the private sector. And that's usually the more simple, less complex procedures, so that we can free up more EBUS capacity. It's very difficult for us to do the more complex procedures elsewhere at other sites. But that's something that needs to be explored, because we need to get our capacity back on track, really. Also, virtual MDTs. This, in theory, is hugely beneficial. It can release capacity of clinicians because there's less travel time, but this really needs the infrastructure to support it, both in terms of IT and admin. And I think we have to really push for that and make sure that we have adequate resources to deliver this, so that we're not trying to deliver virtual MDTs, and actually all it means is that we're delivering a poor quality MDT discussion. Remote consultations, I have mixed feelings about this. I think clearly there is a need there to protect our patients, and it's beneficial to do that, but there are a number of concerns around this. Partly our patient population is slightly older, and they're not always as tech savvy. I mean, I speak for myself, and I'm not very tech savvy. So it can be difficult to have those virtual consultations. For example, with video, I don't know about you, but when I'm in clinic, at the moment, I undertake those consultations by telephone, and I'm not sure how many people I know still who use landline, but my patients do. So we need to be careful about not making ourselves inaccessible through virtual consultations, and making sure we can, and we do see those patients face to face who need to be. But obviously there are many gains through virtual consultations if we have the right setup. It's also, I mean, I want to just mention that at the beginning of October, Professor Sir Mike Rich's report on diagnostics in the NHS was published. And I think that it's hugely important that we implement those recommendations, because it covered so many aspects, not only in terms of service configuration, but also equipment, and hugely importantly, workforce. And I think unless we address those issues in parallel, we really won't be able to deliver this. And I think it is our responsibility to keep advocating for this. COVID or no COVID, our patients still need us.
Thanks, Sadia. That's really helpful. Beth, how is the optimal pathway viewed in Scotland? I mean, technically it's an NHS England document, isn't it? But how is the timelines within the pathway viewed in Scotland, and will you be implementing it?
So for those of you that don't know, I moved up to Scotland 2 years ago and previously worked at UCL in London, and was heavily involved with Neil in implementation of the National Optimal Lung Cancer Pathway within UCL. So moving up to Scotland, I've had to get used to a very different NHS structure in many ways, and different NHS priorities. And one of the clear absences for me was the fact that at the moment there are no plans to implement the National Optimal Lung Cancer Pathway in Scotland. Now, that's not coming from a clinician perspective, because actually discussions amongst most of my lung cancer colleagues throughout Scotland is that we should be pushing the Scottish Government and NHS Scotland to look at implementing the National Optimal Lung Cancer Pathway in the future. I think we have a couple of real significant concerns. Is already we know that per head of population, lung cancer incidence in Scotland is higher than in England, probably largely due to deprivation and geographical locations and the smoking rates in Scotland. We also know that I specifically cover a very remote and rural population. So we, as a health board, I offer cancer care to patients living in almost half of the landmass of Scotland. So we have to deliver lung cancer services equivalent, I would like to think, to those they could get in a big urban centre. But obviously that's much more challenging with the geography and the distances that our elderly population have to cover. We already know that our patients do poorer in terms of outcomes. So the greater the distance from a cancer centre, we know the poorer the survival. And that's something we have to take into serious consideration when we're thinking about our pathway. So although there are no national plans to introduce the National Optimal Lung Cancer Pathway, it is something as clinicians we are striving to achieve regardless of targets that are implemented. One thing we find specifically is often the upfront part of the pathway, which I think Arjun may speak about at some point, is often easier for us to control and to shorten, which surprised me a little bit. We have much greater difficulty with our time to staging investigations, and I know that's something we'll come on to later, and that's largely because of our geographical location. I think one thing we found during COVID, as Sadia's very well described to us already, is that actually a lot of the innovations that were being brought in for the National Optimal Lung Cancer Pathway have been hugely beneficial during COVID. So, upfront straight to CT triaging, so we're not seeing patients in clinic that we don't need to. We are lucky in our geography in that we have a number of CT scanners around the region, and so we were able to have hospital scanners, so scanners in our more remote hospitals that had fewer COVID patients and that could effectively be green scanners. So we were still able to deliver a safe pathway for our patients. Our biggest issue, as I know, has been across the UK is the number of referrals coming in, and as Sadia very clearly said, cough does not mean stay at home. It does still mean get a chest x-ray. And that concerns me gravely moving forward. We already have virtual MDTs set up, and that's the way we run our thoracic surgical services for our patients, and that continued throughout COVID. So we were lucky in that respect. Very few changes to our MDT. We already do a lot of video consultations for our patients, and actually, whilst I am very aware of the limitations that they offer, actually patients do really quite like it. If you ask a patient if they want to sit in a car for 3 hours to come and see me for 20 minutes, most of them say no. Now, that also, we found the benefit of that is that it's much easier for families who are distant from their relatives to be able to be involved in the consultation. And so the individual patient may not be set up with an iPad or internet access, but often family members are. And so we've had real benefits, I think, in terms of including family much more in discussions and complex discussions with patients. And that, I think, has been a slight benefit. We are definitely moving back towards more face-to-face consultations, and we're always more aware, because of our travel time, of bundling up our investigations. So quite often we'll get the CT scan up front, and then we have more of a diagnostic clinic. So a patient will come, see the clinician, get their lung function, often stay overnight, get their EBUS the following day. So we're able to bundle our investigations a lot more. So I think actually in some respects that's helped us to streamline our pathway.
That's great. Josie, if I could turn to you. What's been the patient sort of perspective of the optimal pathway, perhaps, pre-COVID, and then perhaps now that we're living with COVID being endemic? What's the patient view of being rushed through the pathway?
Certainly the patient perspective, both before and during COVID, I think has remained very positive. Patients want reduced hospital visits. If they can get access to same-day investigations, albeit quite tiring, as long as this is explained and patients understand why we're doing this, they're very accepting of this. And I think certainly even during COVID, patients have appreciated the lengths we've gotten to try and make sure the investigations are done in a safe manner as well. So I think it's the speed is always wanted. Patients want a diagnosis yesterday and they want treatment tomorrow, essentially. I think, however, it's really important that we do respect and acknowledge that for some of our patients, and not just elderly, all patients, it's been really overwhelming. Certainly everything about COVID for everybody has been quite overwhelming. People have been scared to come to hospital in some circumstance. So certainly from a CNS point of view, really supporting patients before they come to clinic, explaining what will happen sometimes has been really helpful as well. But I think the overall it's remained very positive.
Great. So Arjun, you'll be very familiar with the front end of the pathway in particular. This bit hasn't been updated and remains as is shown there. One of the challenges I've always felt about this pathway is that sort of -3 to 0 days of getting a rapid report for a chest X-ray and getting them through to CT. Is that still feasible, do you think, in a COVID era? How do we deliver it?
So I think, this part of the pathway, Neil, has always been something that many departments I know around the country have risen to the challenge that it's brought up by essentially reconfiguring their services in line with a sort of central hub model as they have in Manchester, quite rightly, to see if that same day reporting or at least rapid turnaround ideally with a more a more focused request form for lung cancer, high lung cancer suspicion, to basically facilitate the diagnostic probability, the assessment, and the communication of the result to the GP. Many departments have also taken on the ownership of that abnormal chest X-ray report by essentially upfront informing both the GP and the patient that in the event of an abnormality, we may choose to push through a CT directly, as they have in pilots that were carried out by the ACE program in with Cancer Research UK, I think about 4 or 5 years ago now. That data is out in the public domain, so with good results. So that was a nice example of radiology departments delivering on the ideal of this even before the optimal lung cancer pathway was in its published form. But I think for the vast majority of departments, you're absolutely right. It's a real challenge because, for one thing, many places are still having to outsource reporting of chest X-rays, because in the first instance, there's a shortage of chest radiologists. It's one of the key subspecialty deficiencies that the Royal College of Radiologists workforce census identified. And across the board, generally, obviously, we are facing a big gap in radiology provision with a shortage of consultant radiologists anyway. So that, of course, brings that of course has raised the possibility of reporting radiographers or reporting ancillary professionals of whatever description. And again, I think that there are definitely positives to that model, but of course, rightly so, I believe. Those also come with certain penalties that we have to be aware of. For instance, radiographers themselves are in short supply. The Society of Radiographers would tell us generally that they have a big shortfall. Many departments that had implemented reporting radiographers have managed to keep them by and large for appendicular work, but for chest radiography especially, because they are usually slightly more senior, they're very capable individuals, obviously, but when there's a shortfall of radiographers to deliver their primary function, essentially imaging acquisition, then they get pushed off to the shop floor. And then, of course, there's the issue of training provision time for radiologists in training, so registrars, etc. So those are some of the advantages and disadvantages. But especially when there's a highly trained, highly motivated service, as they have, for example, at the Homerton Hospital, where Nick Watson-Eats, one of very, very well-known reporting radiographers, has delivered services and established their cost effectiveness, etc. I think it is feasible. So I think we have a challenge in radiology to try and implement a more integrated model as a response to the optimal lung cancer pathway. And I'll be very honest, I think thus far, some of the limitations have been that it's not been clear that there is actually a financial envelope that comes with this to incentivize a reconfiguration. I think if that does happen and we are able to get our ducks in order with a nice clean pathway for GPs to understand that this is going to happen to patients, that patients also come pre-warned, pre-prepared, as Josie says, so that the anxieties perhaps have been addressed a little early on, we should be able to get this done. But and of course there is that other issue there on the pathway of the straight to CT as well. In theory, I think it's a great idea, but I think the downstream effects of it have to be clear. For instance, what to do with all the incidental findings, etc. These discussions are not different to that of course we hear about with CT screening for lung cancer as well. So I think we are okay on that front. But the hardest thing about these upfront straight to CT reports is generally trying to find the people to report them, because by and large you do need thoracic radiologists, I feel, in other words, people who know what an early lung cancer looks like, because those are the ones we're trying to catch in the vast majority.
Thanks, Arjun. I think we all know that the optimal pathway is designed to reduce the time to treatment down to 49 days. I just wanted to highlight that the revised version just published does allow for a little bit of leeway on that, where there are patients who have been considered for surgery who may be borderline, to allow MDTs to arrange for further testing, like CPEX testing or a specialist referral or prehabilitation, or even a second opinion or high-risk meeting. So there has been some key changes, I think, to the optimal pathway. And I think I would urge you all to have a look at the document that's been shared on the link as well. So let's move on to the second topic, endobronchial ultrasound. So again, another important document has been published by the Lung Cancer Clinical Expert Group and badged by NHS England, which is an EBUS service specification. So this really does highlight, I think, the important difference between a diagnostic EBUS and a staging EBUS. And I think this is now filtered into our clinical practice routinely. So a diagnostic EBUS occurs in patients who usually have advanced disease, and the focus of the procedure really is to obtain adequate tissue for a full predictive biomarker panel. Whereas a staging EBUS is going to provide an accurate nodal stage. And typically that would mean starting at N3 nodes, systematically reviewing N3, N2, N1 nodes, and also sampling any lymph nodes that are at least 5 millimeters in diameter, and also any nodes that are PET positive on a preceding PET scan. And you'll recall that the NICE guidelines from last year state that a PET scan should be performed prior to an endobronchial ultrasound. But Beth, what about staging EBUS in the real world? What do you think the challenges are? And this document in particular, this EBUS service specification, also emphasizes the importance of EUSB, so the bronchoscope being placed in the esophagus. What are your thoughts on that?
So certainly, as far as we are concerned up here, and I know is the case for many of my colleagues in Scotland, just from our discussions at meetings, is that we find our accessibility to PET scanning incredibly limited. So for us, we often have a 2 to 3 week delay for a PET scan, whereas EBUS can obviously be done in-house by our own team, and we have control over those lists. And we've been very lucky in that we have good capacity to do EBUS usually within a week of seeing a patient in clinic. So we do, I have to confess, work slightly outside of the NICE guidelines in that we cannot always get a PET scan before an EBUS because it causes significant delays in the pathway, and we feel often it's more appropriate that we get on and get the investigations done. And if we delayed that EBUS, then you know, that would have a significant impact on a lot of our patients. So the majority of our EBUSs, I think, are done upfront diagnostically, and only after the PET scan subsequently, they may then unfortunately have to have a second procedure if we feel a staging EBUS is clearly required. I think it would be, if we could improve our access to PET CT in our staging investigations, then I think it would be much easier to deliver a staging EBUS more routinely. We find the accessibility to EUSB, we really don't have any accessibility to that. It's very much on a case-by-case basis, asking for a favour from, you know, a friendly gastroenterologist, of which we don't have many that do EUS. So I think that's definitely more challenging for our patient population.
Thank you. Arjun, from an imaging perspective, what do you think the limitations are of PET and CT sort of for this patient group?
So, I mean, I think the on its own, of course, unimodality staging of the mediastinum using CT alone, as we know from the papers prior to PET, generally was essentially had a very high, potentially high rate of false negatives. So essentially sensitivity was much reduced. And I think the PET work generally obviously really raised the profile and improved the case for PET. So, and with integrated PET and CT now, I think the challenge, essentially a negative PET and a negative CT, as you've pointed out in this flow diagram, is essentially quite very reassuring, and especially when it looks essentially like a stage 1. We know, of course, there are times when a larger tumor has the capacity to have metastasized, bypassing the mediastinum, but that's actually quite a rare occurrence, and of course not an issue. There's nothing we can do there because the mediastinum is genuinely cancer-free, cancer sterile. So I think that in other words, the imaging there is pretty accurate. It's just the behavior of the tumor skipping the mediastinum, if you like. But so I think overall we're pretty happy that between using the two strategies concurrently, and of course adding in EBUS as a third leg, helps us with the mediastinal staging. Where I know we fall down, of course, is when nodes are just small, even with advances in reconstruction techniques and slice thickness, so acquisition mechanisms for PET-CT. We know that smaller nodes, usually of the order of 5 or 4 millimeters, so unless there's quite a good concentration of tumor in them, can be missed. And of course, we have seen those, practically speaking, in our MDTs. But I think actually overall, we are at a stage now, I think, where quite confidently we feel that we can make sure that the sensitivity of that combination, especially a negative examination on both, is quite good and has a high negative predictive value. But it'd be interesting always to see because we don't do enough EBUS on those patients, because it's now no longer mandated. I'd always be curious to see now if there is a correlation between imaging suspicion that this should just be an N2 tumor. To me, it looks like it should be, and then everything else on the imaging is saying otherwise. It'd be very interesting to know what the hit rate just on EBUS there would be, because I don't think we know that yet, and quite often we don't go that far because many of these patients don't get as systemic a nodal dissection as they should if they do go to surgery, because we try and be lung conserving as far as we can.
So I think one important group of patients, Arjun, would be those undergoing SABR. So we're commonly faced with patients with peripheral lung lesions, no enlarged nodes and a negative mediastinum. Under what circumstances should they undergo an EBUS, bearing in mind, obviously, we're not going to be getting pathological nodal staging from that patient, and missed nodal metastases would significantly change that person's treatment algorithm. So are there circumstances when you would recommend in sort of an EBUS prior to SABR, despite a negative PET and CT?
I think that's a great question. Well, one thing is, of course, so I guess the two common scenarios we encounter, of course, are when the lesions that are meant to be going to SABR because they were considered not well enough for surgery. Many of them are often the same cases that we could not biopsy, perhaps less due to lung function, but often due to more to location of the tumor, perhaps deep in the lung, etc. Or patient, we didn't want to subject the patient to the potential complication of the biopsy. And in those cases, when you don't have a histological diagnosis, despite a negative imaging investigations and low pre-test probability, I think I would personally I think there is a recommendation there for EBUS. However, I can imagine that the cost effectiveness of that strategy is something that's quite difficult to evaluate. And the second time, I think, is when despite when we do have histological confirmation, the tumor also, and I think that certain types of tumor, for example, squamous cell, etc., which we may be subjecting to SABR. I think in those cases as well, depending again on a case-by-case basis, there may be an option. There may be a good enough justification to be doing it. I think in time, we will obviously be coming onto the issue of liquid biopsy later, but I think in time, we may find that using imaging techniques such as deep learning and liquid biopsy in combination, we may be able to stratify or phenotype these tumors into groups that should require a more aggressive staging.
Thank you. That's really interesting. So let's move on from EBUS to assessing performance status. So this is something that we all do in our diagnostic pathways, as we know, really crucial to patients. It's really crucial because it can determine treatments. One thing that I'm sure you're all aware of is that it was originally designed to quantify toxicity from systemic therapies. And what's been shown repeatedly, particularly from data from the National Lung Cancer Audit and other large data sets, is that the performance status is extremely strongly prognostic. It is to some degree predictive of response, but perhaps nowhere near as well predictive. And increasingly, we are realizing with personalized therapies and perhaps with immunotherapy that these patients may benefit from some of these systemic therapies. And I'll point you to the PEPS-2 trial, which is an excellent UK oncology-led trial published in Lancet Respiratory Medicine earlier this year that showed that patients with performance status 2 still did get benefit from first-line immunotherapy. So, Josie, our measurement of performance status in our clinics has always been a slightly controversial area. Who do you think should be assessing performance status? Should it be the patient, the CNS, respiratory physician, oncologist, or who do you think is best placed to do it? And you know, as someone with a vested interest in the National Lung Cancer Audit, we want that number in the National Lung Cancer Audit, but who should provide it?
I think we should all be looking at performance status continually, not just pre-diagnosis and diagnosis, but throughout treatment. As we know, it can change dramatically from week to week, and certainly patients start to respond to treatment. So it's everyone's responsibility. And I think certainly from a CNS perspective, what a patient might say in clinic in front of a consultant can change when they come out of that consultation, and we discuss things further with them and the carers and the family about what they can do or potentially do or what they can't do. So I do think it's everybody's responsibility. But I think more importantly is actually that we clarify with the patients and carers what we mean by performance status. You know, what is it we're trying to achieve, that they fully understand how this might affect their treatment plan. And they need to understand how they can improve their performance status as well, certainly by exercise, diet, smoking cessation is essential in this. Concordance to medication for symptom management. These are all key areas where they could actually be improving their performance status if it's just still getting a good night's sleep. And sometimes it's the anxiety issues around the diagnosis that obviously can affect everything. And I think that as well, we need to be very honest about performance status. I think despite patients' best efforts, sometimes they won't improve enough to have treatments that they want. And I think that's where the honesty and reality really does need to come into it. But throughout, I think it's so important that we constantly reiterate improving performance status, for improving quality of life, for improving symptom management and improving palliative care. It's key to the entire pathway, but it's everybody's responsibility really to get that message across.
Thanks, Josie. And as we know, performance status is a fairly blunt tool. Several groups around the country have tried to measure, or have been measuring rather, sort of patient-reported outcome measures. What are the key sort of patient-reported measures do you think that we should be trying to take into account in the diagnostic pathway?
I think there's certainly a place for patient-reported outcome measurements, as there is with the patient-reported experience measures, with holistic need assessment measures. There's lots of tools out there. I don't think we can get away from excellent communication skills in whatever we do throughout our consultations, that we know patients are understanding what we're saying and we understand them, and that they've taken on board what's being said. But I think certainly from looking at PROMs and PREMs, I think now with COVID, it gives us an excellent opportunity to do much more research into any measure that we're wanting to introduce into the lung cancer pathway, because there are several of them about. I think certainly looking at our new ways of working, patient experience of this, the effects of remote consultations, I think it's a valuable time to capture their experience. Is that something that they want? Looking at all the positives and the negative aspects how we've been working. So I think, you know, is it a time that we actually design something more specific to lung cancer and what COVID has caused during this pandemic?
Thanks, Tracy. Sadia, there's been a lot of interest in the clinical frailty scale. And I think this is gaining a bit of traction now from many centres, Newcastle, Christie and others, starting to implement this routinely in their diagnostic workup. Do you think it should be used? Should we all be using it routinely?
A couple of things to say. I think I'd agree with you that the performance status is a blunt tool, but we do know that to a large degree it does work in terms of predicting prognosis and predicting tolerance of treatment. One of the criticisms of performance status is this matter that it's subjective, as you've rightly mentioned. But although it's subjective in terms of the absolute number, and that kappa isn't you know, is only of moderate agreement between clinicians. If you look at the category, so PS 0 to 2 versus PS 3 to 4, you get much better agreement. And essentially, they're really the cut-offs that we tend to use in terms of deciding whether or not someone is potentially suitable for active anti-cancer treatment. So I don't think we should be binning performance status just yet. The issues with the Rockwood clinical frailty scale, it's a screening tool, and the role that's proposed really is whether it has a role in stratification of patients in terms of either selecting patients for treatment or selecting of that subpopulation those who might benefit from a comprehensive geriatric assessment, interventions, and by intervention I mean things like OT, physio, dietetics, attention to polypharmacy, and measures like this to addressing mood, for example, to see whether or not those interventions can improve patients' prospects for active anti-cancer treatments, particularly systemic treatment, and whether that in turn improves patient outcomes. The difficulty is that the CFS, it isn't validated in patients under 65, and it isn't validated in cancer populations. It was developed in an acute medical context. So we have to be a little bit careful about how many parallels we can draw between the different services. But there is now there is an initiative to take that forward via the Specialty Clinical Frailty Network, and as you mentioned, the Christie, Newcastle, and in particular Guy's St Thomas's are very active, and they have active frailty programs really to help our patients. As far as I'm aware, the clinical outcomes from those, and they're very preliminary, this is still, you know, watch this space area, it does suggest that where patients have been assessed, screened, and then interventions undertaken in the appropriate patients, those patients are more likely to complete their chemotherapy treatment regimens to completion, and there is less toxicity and improved quality of life for those patients. But what I haven't yet seen is any evidence that it improves clinical outcomes in terms of progression-free survival or overall survival. So I think it's difficult. Having said that, there is also a role for us to consider whether or not this is actually part and parcel of best supportive care. Leaving aside everything else, actually, is our falling patient, are they going to benefit from a geriatric assessment? My gut instinct is they probably will. So I think there are a number of considerations.
Thanks very much, Sadia. So the next topic we're going to, can we have the next slide, please? Thank you. So the next topic we're going to cover is, very briefly, is just smoking cessation. And I wanted to again point out two developments. First of all, that it's a nice quality standard now that adults with on the diagnostic pathway should receive evidence-based stop smoking support. And that's been interestingly worded, I think, because it suggests not just offered, but should actually receive evidence-based smoking support. The other thing to help support monitoring of that is that there's been a change to the COSD version 9 dataset. You'll be familiar with the Cancer Outcome Services dataset that every trust fills in, that provides data to the National Cancer Registry, which also feeds into the National Lung Cancer Audit. And there are two new bespoke items within COSD version 9 that will feed directly through to the National Lung Cancer Audit, we hope, in the future. So collecting not just tobacco smoking status, but also was the treatment for tobacco given to the patient. So hopefully there we'll be able to align data collection and a nice quality standard there. Josie, how do patients tend to react to smoking cessation advice in your experience on their diagnostic pathway?
I think again it does vary. I think the majority of patients, certainly in the initial consultation, do want smoking cessation advice, will accept that, do take our local advice, given sometimes just by ringing a help number. We have Get Healthy Rotherham, so they will take that on board. Certainly anyone having a bronchoscopy or investigations is often enough to stop them smoking. And obviously they get a lot of family encouragement. Sometimes that can be a little bit judgmental, and I think we have to be careful of that. But I think it's not just at the initial diagnosis for stopping smoking, it's also trying to support these patients to continue to stop smoking as well throughout. And especially, again, with the added pressures of COVID, although hopefully people are stopping smoking more, I think our client group, sometimes it may just be too much for them. So I think we need to continue that throughout the pathway.
Thank you.
Yeah, I think it's really important that we acknowledge how difficult this may be for patients as well. So it's always about encouraging them to stop and actually praising them when we know they have stopped, when we're asking them questions, give them some merit that they've actually stopped smoking. I think that's needed as well.
And also perhaps providing them with some of this very strong evidence base we have now for the, for the benefits of smoking cessation, even during and after a diagnosis of lung cancer.
Certainly.
Okay, let's move on to the next topic. So the MDT, this is obviously a crucial part of our diagnostic pathway, part of our lung cancer care. It's perhaps not something that we talk enough about. Arjun, just briefly, what do you think makes a good MDT, and do we need still a separate diagnostic and treatment MDT?
Well, I think the first thing that makes it probably function well and deliver on its intended purpose, is a clear purpose for the patient's discussion. Well, obviously, when it's a diagnostic MDT, I think it's pretty well understood what the purpose is. But for the more complex patients, where you refer to as, which for now we'll call it part of the treatment component of the MDT, I think often, practically speaking, and from a radiology point of view, two things end up happening. First is we don't really have a clear question, usually. The second thing is when there is a clear question, often we find the discussion is repetitive and often has been answered either in the report or in previous discussions, but hasn't been communicated. And that leads to the second thing, which makes the MDT probably successful, if it's going to be, is a clear outcome and clear communication documentation that everybody ideally is actually able to sign off on in real time before proceeding to the next patient. And I'm aware that is, that sounds idealistic, that sounds impractical, but in many places, I think, for instance, where my old patch, Guy's and Thomas's, it was possible for everyone to have a quick look at the outcome, make sure that the poor oncology registrar who was typing up the outcome didn't feel unduly pressured to synthesize all this amazing data into one cogent summary. But everyone actually was responsible for their own bits. So there may actually be a way to communicate that much better. But going back to that point about diagnostics, etc., I think that's right. I think often we may not need, for the clearer cut cases, we may not need to discuss this. That's controversial, I know, but other than a rubber stamping exercise. But that will only happen, I think, if we make sure that patients are being referred to the MDM with a full template of investigations already performed, the minimum data set, if you like to call it that, so that everyone can actually make an informed decision quickly. Because otherwise, as you know, we spend a long time pushing these patients through what is essentially a very well documented pathway that should be happening prior to them coming, and they end up being discussed on that MDT far too often before any decisions can be made.
Thanks, Arjun. Beth, very briefly, I've always been interested in where the medical legal standpoint of MDTs, and actually there was a really interesting paper published recently specifically addressing this. Just very briefly, can you take us through some of the key points?
Yes, so this is a really interesting one for me because it's not something I'd really given any active thought to, and I think that's probably similar to a number of my colleagues. I've always felt very reassured by the MDT that the whole purpose of it is it makes your cancer pathway more efficient. It's associated with improved survival, better adherence to guidelines. It's there almost as a medical legal support in itself to make sure that your patients are getting the best treatment according to the current best practice. But I hadn't really clearly thought about the medical legal responsibilities of the MDT in reverse. And so I think this paper has been really interesting. And you know, a number of things that stood out for me is issues over patient consent and privacy, and I think again we discussed this offline before the meeting. This is I don't routinely say to my patients or gain consent from my patients to discuss it at the MDT because I consider it best standard practice. But actually from a medical legal perspective, it may be that this is considered an additional consultation or an additional discussion with other colleagues, and actually their recommendations are that you should gain formal consent, and that should be documented clearly in medical records before you discuss a patient at an MDT. I think another issue that often arises within our MDT is around whose responsibility is it to deliver the outcome of the MDT, who carries that through. Now, the way we run our MDT is that really all patients are usually discussed with a member of the lung cancer team beforehand. So even if we haven't seen them in person, we've had a consultation or a discussion with the referring member, and we document very clearly in our MDT which individual MDT member is responsible for carrying out the actions of the MDT and communicating that to the patient, to the GP, to the referring doctor. But interestingly, in the paper, they're suggesting that it's really the responsibility of the referring doctor who refers into the MDT. Now, I think that's fine when it's one of the core members of the MDT or someone who is used to delivering, you know, cancer care or lung cancer care, but that does make me slightly concerned if you've got, for example, an orthopedic team asking a question and then they're responsible for communicating that with the patient, because it may be that they're not in a position to answer the questions that the patient may have. So I thought that was also an interesting outcome. And then I think probably my favorite one is how do you deal with disagreements within the MDT? And this is something we have not infrequently. You know, can everybody truly agree on a final outcome? I have to say most of the time that is the case, but it is interesting from a liability perspective. The evidence or the data in this paper is suggesting that actually if somebody feels they can't support that decision, that should be clearly documented. And often what then should happen is that the different possibilities should be discussed directly with the patient. And again, that's something we often have with our MDT, is that we have, you know, maybe two choices, and those are then discussed in more detail with the patient.
Thanks, Beth. Really interesting, I think, from a medical legal perspective. Sadia, just briefly, I've always wondered about how we work out what a good MDT is. Are there sort of metrics, do you think, that we should be measuring, that we can audit ourselves to work out whether we are a well-performing MDT?
I think you've given me the hardest question of the entire agenda. I think trying to assess the performance of our MDTs, by which we mean the whole team rather than just the meeting, is complex and difficult and nuanced. I've just highlighted two reports you'll be familiar with. The one's from the UKLCC at the top in 2012, and the second is an NHS England publication last year about streamlining MDT meetings. And then there's also this publication in CR UK, and I'm just highlighting this because that graph shows, in my view, the fundamental reason why we have any problems with our MDT as a service. And that's basically demonstrating that the activity of the MDTs have increased hugely, and yet the workforce really hasn't. So we're under pressure, and I think that's what leads to our difficulties. In terms of how we can measure it, well, I mean, you've touched on the NICE quality standards, and they set out what they define as high quality care areas for improvement. But this can be really summed up as assessing our performance against national standards. And there's lots of national guidance out. There's lots of NICE guidance, peer review, etc. There's NOLCP. We can measure ourselves against numerous metrics, and we can keep doing that all day, every day. But all of that really is a means to an end, and that end is patient outcome and patient experience. And I think we have to be better. We do have measures of patient outcome, but I think one area where I think we're weak actually is in assessing patient experience of patients in our services. We do have the National Cancer Patient Experience Survey, but if you drill down, when you try to look at the number of patients in your service in a particular trust, the numbers are very small. And when you look further, the responses, it's very difficult to tease out what the responses refer to, whether the information provided was adequate in the respiratory medicine or oncology or radiology. I think we need to have much more institution-based data around patient experience. The other thing I think we should be better at is, I put it as a category of timeliness. This isn't just about performance against the faster diagnosis standard and the NLCP treatment time. It's also, for example, you could look at effectively the efficiency of an MDT. So, for example, what proportion of our patients will end up on the diagnostic standards of care pathway, where they're not formally discussed at an MDT unless there's a very good reason for complexity, and they're managed outside of that, but still looked after by the MDT and still tracked appropriately. We're also, I think, not great at screening every single patient for every eligible trial, and that might be worth something that actually we are much more aware of and that's fed back to us directly. I know I'm guilty of this. I barely remember. In busy clinics, I don't remember at all. And then this might be a little bit far out, but I do wonder whether we actually, as a public body, as the NHS, actually should be undertaking equality impact assessments of our care. And by that, I mean whether we are delivering. We hear a lot about, unwarranted variations in care, but are we really delivering equal care to all our patients? And I think there are formal ways of assessing that for public bodies, and I think we don't have that for MDTs. But if you add up the number of patients in our services across the country, I think that is something that we should look at, whether that's to do with protected characteristics or whether it's to do with, for example, age or urban versus rural living. I think that's something that we probably should be looking at further.
Thanks, Adia. That's food for thought, isn't it? Just in the last few minutes, I want to touch on something that's approaching us rapidly, I think, from left field, that we all need to be aware about, I think, in our diagnostic pathway, and that's about liquid biopsies. I've always personally had a bit of an issue with the name because it's not obviously a biopsy, but we all understand the concept, I think, of detecting circulating tumor DNA within blood. Some people use it as well, I think, loosely to look for circulating tumor cells as well. And there's been plenty of investigation currently that's happened and ongoing in the screening setting. Lots of excitement about its role in minimal residual disease and the role in adjuvant treatments, detecting relapse, very good data already from TracerX showing that. And then perhaps even as biomarkers for using targeted therapies, and obviously making a diagnosis when tissue is not adequately available. And then perhaps most commonly we use it in the UK for looking for acquired resistant mechanisms after first-line treatments. But Arjun, if I could come to you very briefly in the last couple of minutes, does this mean that once we take into account sort of volume doubling time and we use EBUS for the mediastinum and we've got peripheral staging with PET, does this actually mean that CT-guided biopsies might go out of fashion?
I obviously will say they will never go out of fashion, but I'm going to try and hopefully justify that. Nothing would please us more than to be doing more useful CT-guided biopsies. And I think actually this will probably help to get us there by integrating imaging biomarkers and essentially what is a circulating biomarker. I think we should be able to get to a more specific pretest probability, a higher pretest probability, and that will help us work out two things: whether or not we will be happy to do away with tissue obtained from percutaneous biopsy as a gold standard and settle for a silver standard of high diagnostic confidence, which many services would argue is a threshold of over 70% in lieu of obtaining histological material. And as you know, we do that. We've been doing that for more than 10 years now in the interstitial lung disease setting, when biopsy rates have fallen tremendously, but obviously for a different disease category. So I think actually it won't displace CT guided biopsy, but I think it will actually help us make sure that we do the biopsies in the patients that most need it, and perhaps also it will probably, I think, revolutionize the molecular imaging that we do. To help us make sure that we target the bits of tumor that are probably going to give us the best areas for yield, and perhaps also help us not do biopsies on tumors which are too heterogeneous, where we can't rely on the biopsy result itself. But quite a lot of work to be done to work out the sensitivity and specificity of these treatment strategies before we get to that era, I think.
Great. Thanks, Arjun. And I think as this space develops, I suspect the liquid biopsy is going to become part of our routine diagnostic pathway, but we'll obviously have to watch that space with interest. So we're at 6:30. I want to thank everybody for their attention. I want to thank particularly colleagues at BTOG for arranging this, and the IT colleagues as well who have set up our lovely platform, and particularly to thank our panelists for the engaging discussion. Just as the last slide, just to say that please find time in your diaries if you can for our next webinar, which is on Thursday, the 3rd of December at 5:30, which will be a masterclass on stage 3 disease. So thank you everyone again for your attention, and have a very good evening.